to this MTE session on hypogonadotrophic hypogonadism.
So let me introduce you first.
That's what I was thinking.
Yeah, so we have Dr. Subrata Dey, Senior Consultant Pediatric Endocrinologist at Apollo Multispeciality Hospital, Kolkata, and he's going to introduce our speakers, and we're going to have a wonderful session on management of hypogonadotropic hypogonadism. Yes, sir, all yours.
Thank you for that timely reminder. So welcome back, all the ISPE and other members. Let me not waste any time. Dr. Nalini Shah needs no introduction. And I think she spoke yesterday as well. But essentially, she was the president of the Indian Society, ISPE. She has 220 publications. And my association goes back to 1985 with her when she was in CMC Vellore, where I was a DCA student and she was young faculty. So welcome to the show. We also have now Dr. Manjari Karlekar, Assistant Professor, Department of Endocrinology, GS Medical College, and KEM Hospital. Welcome to the show. So with these words, let's start. Go ahead.
Yeah, thank you, Subrata Dey, and ladies and gentlemen, thank you for being here in this hall. I know there has been sort of a meeting which has just got over, but all the same, let's begin with approach to management for patients with hypogonadotropic hypogonadism. What Manjari and I have tried to do is that we've just tried to collate our experience that we've garnered in our department, and I've tried to make this a very, very clinically orientated kind of a scenario. And I do realize in the audience we have some big wigs, so we're going to have some help from Paul and Margaret as well. And so please do help us out, all of you. So let's begin here. The whole session is divided first into diagnostic approach, then we get on to the representative case scenarios, and then we get on to the management in terms of its principles, and again represented with our relevant case scenarios. So if I just talk about this particular child who is 14 years old and who presents with delayed secondary sexual characteristics, this is a very common referral, and this is the typical age group at which this referral really comes. And the question then comes up is, how does one clinically approach them, and what are the relevant test parameters that one would use? What are the cautions in interpreting these test parameters, and the performance of these tests? How do they fare in different clinical scenarios? Does one really need to fall back upon genotyping these individuals, and what kind of yield is this genotyping going to hold? And finally, what we are most interested as clinicians and of course as a family member for those patients is, how do we really manage them? So we know that puberty goes through these multiple phases starting from early fetal life, where it is completely governed by maternal HCG, which in turn sort of governs the functions of Sertoli cells, the Leydig cells, and we have the complete formation of genitals, which is taken over then by about 15 weeks of gestation by the HPG axis of the fetus. The mini puberty begins somewhere at just before the birth and sort of continues in a male child till maybe about 3 months to 6 months. And then we have typical events of puberty which really follow, which is governed by all the central parameters, the hypothalamo-pituitary axis, which in turn governs the testicular functions, namely the Sertoli cell function and the Leydig cell function, respectively. We do understand and realize the cutoff or sort of a working definition of who should really be called as delayed puberty, but we understand the flexibility of this definition. We don't want to wait till 14 years of age. We are more than happy, even in a young infant, to call and make a diagnosis of hypogonadotropic hypogonadism, and it works across the whole span right from birth to puberty. So 14 years is not a sacrosanct event, but till 14, if there are no beginning or no signs of puberty, it definitely sets off a kind of concern in the mind of parents and the physicians alike. The representation of delayed puberty or its manifestation varies across the lifespan of an individual, starting with micropenis and cryptorchidism at birth itself, to just a partial or complete absence of puberty. It can even be complete development of puberty, which presents only with infertility, or just a physiological delay in a start and tempo of puberty, like constitutional delay. It could be truly a state of delayed puberty which reverses itself spontaneously or under the influence of sex steroids, as it is known to be, or it could be an adult who's fully sexually mature or even could be fertile, who kind of reverses the entire cycle to become hypogonadotropic hypogonadism, which is also well described phenomenon. Hypothalamic amenorrhea is also sort of put together under the same spectrum of differential presentation of delayed or arrested puberty in an individual. These are the four common group of causes that we deal with. The two central causes, the delayed puberty, which is self-limited delayed puberty, or permanent state of hypogonadotropic hypogonadism, which works as a closest differential diagnosis. And as a clinician, it is our sort of job description to try and differentiate between the two, because that's what is going to be the governing factor in terms of prognosticating and, of course, putting together the management as well. Hypogonadotropic hypogonadism is relatively less difficult in a clinical scenario to kind of put together as concern or as a diagnostic challenges. And when we talk about these etiology and its relevance in terms of commonness, it's the constitutional delay of growth and puberty, which can account for nearly 60 to 70% of individuals who present with delayed onset of puberty. So the first part of the entire assessment needs to rest on either a systemic or an underlying metabolic event which is leading to functional state of hypogonadotropic hypogonadism. And we always try to work together towards a general assessment of the child and these basic set of investigations to make sure that it is not systemically driven cause which is giving a delayed onset of puberty, which is something which is really, really well known, and we have encountered that even in patients with CKD presenting as delayed onset of puberty. So it's something which ought to be addressed first before going ahead with assessment of hypothalamo-pituitary gonadal axis and its assessment. And in the same context, if we are now looking at either it is hypogonadotropism or hypergonadotropism, the clinical cues are useful. The arm span will be much longer in patients with hypogonadotropic hypogonadism versus hypergonadotropic hypogonadism. Gynecomastia is far more prevalent in hypergonadotropic hypogonadism. It is not absent in hypogonadotropisms, but it is less common and less pronounced is the way we would want to look at it. And of course, the gonadotropin levels, which are so easily available, would clinch between the hypergonadotropic state versus inappropriately normal or low gonadotropins in presence of low circulating sex steroids. So that would be kind of a clincher out there. And when we are talking about then either a differentiation between a self-limited or just change in the tempo of puberty versus a permanent state of hypogonadotropism, we kind of understand that there are multiple test parameters which are available to us to find out the functioning of hypothalamo-pituitary axis, Sertoli cells, and even the Leydig cells. And these test parameters are something that we are quite conversant with, and we'll just come back to it. When we are talking about these clinical parameters, one thing that I would like to consider quite important and something which we should always sort of bring together in our clinical assessment as a focus is a sense of smell. It definitely helps, and it's amazing how patients themselves have not appreciated it till you bring it out and ask as a leading question. And I think it's quite important, and time and again it has been a great help to us in addressing our children and sort of that age group, which is sort of very difficult to address between the test parameters as well. Sense of smell is important. Also, these extra reproductive phenotypes, though I have put down over here in diagrammatic representation very gross kind of a phenotype, but subtle phenotypes like a cleft lip, which has been sort of so well managed with plastic surgery that it is not obvious, but it was something which was always present, will always take you away from a constitutional delay of growth and puberty, and so on. Hearing defect, many of our children, they're not even aware that they have a hearing defect. And when we kind of formally test them, we come out and realize that the hearing defect was always present. Small changes like polydactyly, syndactyly, any of the abnormalities on the limbs and in the fingers, toes, is something that one should be taking note of, and they would be pointer towards associated non-reproductive phenotype which could be present in patients with hypogonadotropism. And I would say that these are important cues to work with. Of course, the syndromic causes are very, very rare, but important again. So looking at eyes, looking at these hair flocks which you pick up and you suddenly make a diagnosis, looking at a patient with Boscher-Neuhauser, where he presents with cerebellar ataxia to the neurologist and then get referred to you because of the pubertal delay that has been experienced, or just looking at the teeth of this individual who's got a 4H syndrome. All these subtle signs are kind of helpful, and I would certainly pay attention to them because according to me, they are far stronger as a signages towards central causes compared to the outcome and accuracy of your test results. Also, the mode of inheritance are very useful and important. Some of our young children who presented at 8 years of age, 10 years of age, when the parents felt that the growth of penis was sort of lagging behind and you are kind of in dual mind, and suddenly you have a history that the mother's sister's son also has anosmia and is under treatment for hypogonadotropism, you know that you're dealing with X-linked mode of inheritance. Or one of the two siblings that Manjari is going to discuss, who obviously came from a consanguineous union. Again, those kind of scenarios are useful pointers towards aid in differentiating the cause for delayed puberty. In our own spectrum of understanding and publications, because we went through this exercise for a period of, I would say, 15 years in understanding the genotyping our patients with hypogonadotropic hypogonadism, what we realized is that there is a huge difference regionally in terms of genetic yield, and we are now talking about only NGS-based yields. We're not talking about Sanger-based yields in these individuals. So even with NGS-based yields, it is regionally different. There are hotspot of mutations or founder mutations which are very region-specific, which we have seen in our review of literature. And also, as a very broad principle, or as a broad rule, if I can project it, patients with more severe phenotype are more likely to have genetic yield which is positive. But even in the best case scenario, the genetic yield in these individuals sort of tends to be in the range of 20 to 30%. So genetic yield is not going to be, it's not like a pheochromocytoma, for example, which is like 70 to 80% in childhood. This is just about 20 to 30%. So if there are supportive non-reproductive phenotype, if there's a strong family history, if there's a newborn who presents with severe phenotype of micropenis and cryptorchidism, we know that the genetic yield is going to be definitely higher in them. So far, what we have discussed is just the clinical layout of the scenario and the genetic sort of feel of underlying genetic mutations. If there are any questions in these two domains, we are more than happy to take them. No? In that case, we'll just proceed further. So the most important causative factor that we want to consider is these kind of central lesions as acquired causes of delayed puberty or arrested puberty. The top panel being craniopharyngioma and the bottom panel being giant prolactinoma. Both of them are going to have extremely different mode of treatment. The top is what we are going to surgically managed, whereas giant prolactinoma was managed beautifully well with medical management per se. So these kind of underlying etiologies are something that we want to look out for, and we always try and elicit which of these patients are going to be meritorious of being imaged centrally, because that's going to change the management of these patients completely. So how do we really go about assessing between a congenital cause and an acquired cause, both clinically and biochemically in these group of individuals? So there are set of tests which are available which try and estimate the functionality of hypothalamo-pituitary as a unit, Sertoli cell as a unit, and a Leydig cell as a unit. These tests have been around for a very long time, and each of these tests and their performance is what I'll just like to refer to just bring home its diagnostic accuracy and its diagnostic challenges as well. So this is a paper which quoted the role of inhibin B as a marker of Sertoli cell function after testosterone priming. This paper actually studied testosterone priming based yield of GnRH stimulation test and inhibin B. But what you can really appreciate that even in this cohort, what was most remarkable was to look at the height ST scores and the testicular volume. The patients with constitutional delay in puberty were much shorter compared to hypogonadotropism, and the testicular volume were better in constitutional delay compared to hypogonadotropism. And that's something worth noting. It tells you that these are two different ends of spectrum of severity that you've taken as a cohort, and the test performance is going to be governed with that, is what we need to be kind of conscious about. This is a test scenario which was published way back about, I think, maybe 15 years back, 2009, 15 years ago. Again, two groups of patients with constitutional delay and hypogonadotropic hypogonadism subjected to three set of tests: GnRH stimulation test, short HCG stimulation test, and a long HCG stimulation test, to come at these cutoffs as which are depicted over here, and to give a conclusion that when you combine all the three tests, you get a diagnostic yield which is 100% in sensitivity and in specificity. And Manjari is just going to take us through the case scenarios where these diagnostic yields do get challenged. And the reasons they get challenged is also what we would like to discuss with you. This is a group of papers which have talked about inhibin B in basal state, post-testosterone priming, and post-FSH priming with different set of cutoffs. And you can see the yield, which is beautiful compared to basal. The stimulated values of inhibin B have been nearly yielding towards 100% sensitivity and specificity. Again, we'd like to just use them as our fulcrum to bring home some challenges which can be encountered in a clinical scenarios. This is a test which is extraordinarily kind of labor intensive, I would say. It's GnRH pre-primed, kisspeptin stimulated inhibin B and LH values which were studies. Yes, there is a great distinction which is achieved between patients who progress through puberty versus patients who did not progress through puberty, but that is a kind of set of tests which is more like a research tool and probably not accessible for clinicians, and also its labor intensive nature of the blood draws that one has to go through. So these diagnostic challenges, how do they really fare, is what Manjari is now going to discuss with the case capsules.
So having seen the various tests which we can utilize to differentiate between constitutional delay of growth and puberty versus hypogonadotropic hypogonadism, I would be discussing case scenarios where these tests and cutoffs helped us in making the diagnosis and where they failed us to conclude as to what the diagnosis of the patient is. So coming to the first case scenario is that of a 14-year-old male who comes with poor secondary sexual characteristics and small sized genitals. On evaluation, his height is on the 50th centile, but his genitals are prepubertal, and so is his biochemistry. Now, but if you look at his inhibin B level, it is 106. And if you look at the cutoffs which I have represented below, which has a good sensitivity and specificity, he is way above that cutoff. So therefore, keeping these cutoffs in mind, we decided to follow up this patient, keeping the provisional diagnosis of constitutional delay and of growth and puberty. And subsequently, over the next 2 years, this patient did enter puberty, and at the follow-up of 16 years and 7 months, his testicular volume had reached up to 10 cc, and his testosterone had gone up to 2.7 nanogram per ml. So this is a case scenario where the baseline inhibin B value was very useful in reaching a diagnosis. But let us look at the next set of cases. Here is a pair of siblings, one 5-year-old and the other 3-year-old, both of whom come to us with micropenis. They have bilaterally descended testes, which are less than 1 cc. Because they are siblings and have a history of born out of a consanguineous marriage and micropenis, we decide to utilize the stimulation tests in them. So the HCG stimulation test is done in them, and both of them pass this test. Both their values are above the cutoff of 1.08. The elder sibling has a value of 1.26 nanogram per ml of testosterone, and the younger one a 1.23 nanogram per ml of testosterone. We further go ahead and do a GnRH stimulated LH value for both of them, and again both of them cross the cutoff values which are required for diagnosis of hypogonadotropic hypogonadism. What are we dealing with then? Therefore, we further go ahead and do a genetic analysis for them, and to our surprise, both of them turn out to be KIS1R intron 3 homozygous mutation positive. So this is a classic example of where these tests can fail us, and it was actually a pair of siblings who were having congenital hypogonadotropic hypogonadism, and this is the scenario where you may want to have a relook at these cutoffs which have been established for diagnosing them. Another boy, a 1.5-year-old boy who presents with bilateral cryptorchidism and micropenis. He has undergone orchidopexy for the same, and at age of 1.5 years, his biochemistry is appropriate for his age. He receives, for his micropenis, he receives injection testosterone. Subsequently, his stretched penile length improves to 3.5 centimeters. And he represents to us at the age of 4.5 years, and we do a HCG stimulation testing in them. A 3-day test as well as an extended test. And again, he passes both these tests. His day 4 value is 1.2, way above the cutoff, and again, day 22 value is also above the cutoff, which is there for diagnosing these patients. So we decide to follow up this patient even further. He presents again at the age of 12 years and 8 months. His height is at the 25th centile, and he's still prepubertal. What do we do next? So we do an MRI for him, and we do find hypoplastic olfactory bulbs in him. And when we relook at his history, when we ask a detailed history, he does confirm a history of hyposmia, which was missed on the initial evaluation. Nevertheless, we still go ahead and do the stimulation tests in them. And although the basal inhibin B is low, that is 35 picogram per ml, his FSH stimulated inhibin B again crosses the cutoff, which is 143 nanogram per ml. His cutoff, his level is 143 picogram per ml. He also does pretty much okay in the GnRH analog stimulation test, where his cutoff, he's just at the cutoff of 2.8 of LH value at 2 hours. Therefore, we further go one step ahead and do a genetic diagnosis analysis for him, but he turns out to be negative for genetics. So what are we actually dealing with? So because of the non-progress of puberty at 12 years, and because he had all the red flag signs of hypogonadotropic hypogonadism in the form of anosmia, micropenis, and cryptorchidism, we decide to treat him with gonadotropins. And subsequently, he has progressed beautifully through puberty, and at the age of 15 years, his bilateral testicular volume is 8 to 10 cc, and his testosterone is also good on both recombinant FSH and recombinant UCOG. So these were the set of cases where these tests failed us in diagnosing a patient with congenital hypogonadotropic hypogonadism, and therefore you should always utilize these tests with caution when you are trying to differentiate between these two case scenarios.
So I think we have to close this. Yeah. Right. So I think basically the whole point over here is that these cases are just representative to suggest that the test cannot be used in isolation, and the test performance is governed by factors which are completely the papers which are published and the cases that we select in our clinics to apply these cutoffs are not two similar set of conditions. And that's what we have learned in ourselves. What this really represents is that unless you have a cohort of hypogonadotropic hypogonadism, which is a full spectrum, not just the severe ones, the minute you go from very severe cases and complete delay of constitutional nature, the performance of all these tests are going to be very, very good. But the minute cases of partial hypogonadotropic hypogonadism come in, the performance becomes blurred and the distinction between the two entities becomes very difficult. Also, what really needs to be realized is that GnRH as an IV preparation is not very easily available in India. So most of us are now using analog-based stimulations. So when you use analog-based stimulation but use the cutoff of GnRH stimulation, there is going to be a difference. The analogs are much more powerful stimulus that we are using, and it's likely that even in patients with partial or severe pubertal delays, it can bring in the result towards suggestion of no problem in terms of onset of puberty, and that is one of the caveats we will have to consider. So here is a paper which I'd like to draw your attention to, published in 2020 by Jacques Young and his group on a fairly large number. That's one of the strengths of the paper. The second strength of the paper rests on the fact that this paper is not just based out of pediatric endocrine service-based practice and patients. It is both pediatric and adult service related patients. So the spectrum of puberty is right from severe to partial, because that changes the performance of the tests completely. And what they have shown is that when you use GnRH stimulated LH as a cutoff, hardly any patient with constitutional delay in puberty has a cutoff of LH below 4, but more than 40% of patients with hypogonadotropic hypogonadism will have an overlap between the value of that generated for hypogonadotropism and constitutional delay. So the overlap occurs in nearly 40 to 43% of patients, where you will not be able to differentiate between the two set of clinical problems. And that happens because the performance of this particular test is entirely governed by testicular volume. So if you kind of notice, the performance of the test is dependent upon the more severe is the phenotype of puberty compared to the milder phenotype of puberty. The differentiation between patients of constitutional delay, which is the black bar, and hypogonadotropic hypogonadism disappears completely. So the significance level which was seen at severe puberty versus patients with milder or partial puberty related derangements is completely disappears, and that is what we need to appreciate. So performance of the test will always be dependent upon the testicular volume, and that is a learning out of this particular paper. And the same thing happens in inhibin B. When you look at inhibin B in its nascent or a basal state, you will still have an overlap of 40 to 45% of patients who will suggest same numbers between partial hypogonadotropism and constitutional delay of puberty. And as the testicular volume goes up in partial hypogonadotropic hypogonadism versus constitutional delay, this difference in inhibin B level will start becoming less significant. So testicular volume is one parameter which is going to alter the performance of this test, is what we need to appreciate and respect when we are looking at this test performances. So coming back to these two children of constitutional delay or hypogonadotropism, yes, your clinical picture and evolution of problem on follow-up has got its own strengths if you have taken out and ruled out an acquired cause which immediately requires attention in terms of surgery. In constitutional delay, you may take a path of treating them, and the treatment options are between letrozole and testosterone. Letrozole being one of the recent development, and that paper I think has been fairly useful in understanding what it does to the testicular volume, which is the parameter which lacks with testosterone-based treatment, and to the growth velocity. So if these are the two outcome measures which are utilized, letrozole has got a betterment of outcome towards enhancement of testicular volume as well in these group of patients. So whether you want to push the puberty or you want to make a peace with it, the call rests between the family members, the patient, and the physician alike. You can take your own call and decide how to go about this management. One should always be prepared for the rare causes which could still mask and present as delayed puberty, but they actually belong under the cadre of DSD. Like the first patient on this side, which is a case of Leydig cell hypoplasia presenting at 18 years of age with delayed puberty or incomplete development of secondary sexual characteristics with all the features: arm span which is bigger than height, smaller testicular volume, and micropenis as well. and the other two siblings in the other panel of photograph, which have got 17 alpha hydroxylase insufficiency with no ambiguity of genitalia whatsoever in them, and they were both normotensive as well. So that part of differentiation will always have to be borne in mind as well. So managing these patients is the next port of call that we'd like to discuss with you. Management with testosterone is something which is known for longest period of time, and with different preparations of testosterone as well, being used in escalated doses over a period of time with very good results as it relates to secondary sexual characteristics and changes in body composition, height gain, muscle gain, and the stamina which improves in these group of individuals. What lacks in this kind of scenario is the fertility related management, and towards that one should be a little careful about using testosterone as a word go in these patients towards the end goal of just secondary sexual characteristics, and whether we should be revising our goals in managing these patients is a question that we should be asking ourselves. Fertility induction as a management or as one of the goalposts in managing these children is addressed very long ago, right at 1980, and that is something which is very, very well known right from then. It is just now that it is increasingly being recognized and understood as how it should be used effectively with differential goals right from onset of puberty to fertility, and now taking it even a step further, even for the management of mini puberty. So this is our protocol. This was our protocol where we used to use conjoined treatment with both HCG and HMG as pubertal induction regimen in these patients, with fairly good outcome in these group of individuals, where they could be then taken through the milestones of puberty and sustained either with HCG alone or with androgen based therapy as the parents and the patients so desire. And this is a example of the same that I'd like to suggest to you. The child who came to us as an adolescent at 14 years of age with history of lack of secondary sexual characteristics, history of anosmia was extraordinarily helpful, and he was proven to have Calvin mutation, which is an additional strength as well. Based on that, he was taken through pubertal induction regime as a combined regime with HCG and HMG, did very well with right through to spermatogenesis with a sperm count of 10.5 million. And this is what he kind of really looked like at the end of pubertal induction. Patient was very happy, and of course the family members were very happy as well. So that could be one of the very sort of rewarding kind of an outcome that you go through. Of course, we've taken this a step further as well, because as a department we look after both pediatric arm and the adult arm of endocrinology. Time and again, when patients come to us at older age where the goals are different and socially related to fertility-based management, we've taken them through this regime and with good outcome towards fertility as well. Extending that further towards management of mini puberty is what we have learned further, and which is what we would like to share with you. Sorry. This is the first young newborn a new infant, a 3-month-old infant, 11-month-old infant, and a 10-year-old boy. Each of them clinically suspected and genetically proven to have hypogonadotropic hypogonadism, with micropenis, with bilateral cryptorchidism. And in a set of second panel, you can see each of them who have been treated with gonadotropin-based regime towards improvement in micropenis and descent of testes as well. So the goal of managing testicular descent, which is the function of the last part of gestation where the mini-puberty kicks in with a continued mini-puberty postnatally, when most of cryptorchid gonad in normal population, which is like 0.1 out of 1,000, will descend down, is what we try to mimic in these individuals with fairly good and successful result, is what we would like to share with you. So extending this further and understanding its layout in mini-puberty should follow under these principles. We kind of try and figure out if there are red flags, micropenis and cryptorchidism being the most important one of them. Additional non-reproductive phenotype could be helpful. We may need to fall back on the family history as well, and associated genetic yield through finding out on NGS, like on each of the patients, because we didn't have enough sort of courage to just go de novo in them. We had done their genetic test and we had proven them to be genetically hypogonadotropism. So confirm the diagnosis and then get on to their management to give them the yield towards enhancement of mini-puberty. And why is it so really important? Well, mini-puberty becomes very, very important because what has been learned over time and again, right from older data to the newer data, is predictors of fertility. One of the most important predictor of fertility is testicular size. And testicular size in mini-puberty gets enhanced through growth of Sertoli cells, enlargement of seminiferous tubules, which is the basic function of Sertoli cells to nurture the germ cells really. And that is what brings in the added value of using mimic towards mini-puberty in these group of individuals. So this is one of the older data of 2009 and 1988 that we are presenting to suggest predictor of fertility is testicular volume, and this has been proven time and again. And even in our own cohort, what we realized that when you have severe phenotype, that is a testes which have not really gone through the mini-puberty, prior androgen exposure, which probably curtails the proliferation of Sertoli cell, may hamper the outcome of these individuals, as shown in this red bar, towards both spermatogenesis and even in function of Leydig cells. Compare that with HMG pretreatment in the severe phenotype, which definitely had better yield towards spermatogenesis, and you can see the numbers for yourself. Also, this is something which is reflected in literature time and again, and this is one of the early papers by the group which I'd like to suggest to you, which clearly demonstrated that FSH pretreatment in these group of individuals brought better increment in testicular volume, both when they were treated with gonadotropins or with GnRH pump-based therapy. So FSH pretreatment, which is used towards mimic of mini-puberty, is useful, is the learning part of the curve that you go through. And that's how our own protocol has now changed to bring in HMG pretreatment, monitor it with inhibin B towards betterment of response in the testicular volume, and then add HCG in these group of individuals. This is our own published data in terms of prior testosterone-based regimes, whether they really have an impact on spermatogenic responses in patients with hypogonadotropism. So in our own practice, what we have tried to do is that patients who present to us with congenital hypogonadotropic hypogonadism and have severe phenotype, we try and use FSH pre-treatment in these individuals, and we try not to expose them to androgens as a pre-treatment so that the Sertoli cell population is not curtailed in these individuals. And what needs to be understood and reflected upon is an acquired causes of hypogonadotropism because they've already gone through mini puberty. These patients have already been exposed to FSH based mini puberty with a good number of Sertoli cell population which is available. They can have FSH sparing effect, and they do better with only isolated HCG based regimes, even will work towards enhancing fertility in these individuals. So to conclude, clinical features are very good guide in differentiating different etiologies, which will be essential to guide the management of these group of individuals. If we confirm that it is isolated or as a part of multiple pituitary based deficiencies, which is congenital in origin, then we may consider gonadotropin based regime all towards treatment of micropenis, resort to non-surgical modality of testicular descent, pubertal induction and fertility. Prior androgen therapy should be used with great caution, especially in patients with severe phenotype of hypogonadotropism, and prior FSH based regime do have an enhancing role in increasing the prospects in future towards enhancement of fertility, which is the ultimate goal in these group of individuals. Ladies and gentlemen, we are very happy to take questions at this junction.
Thank you for a very lucid and moving description in the cases. Can I have the prerogative to ask the first couple of questions?
Of course.
I've heard this talk several years ago. Clearly, our understanding has improved over the years, especially with genetic diagnosis, and quite reliably so. But we have in this presentation concentrated on the ones who had certain telltale signs even early on, and so we don't have to wait till 14 years. And clearly, the paradigm shift in this talk has been, instead of resorting to testosterone, which we have tried in the past, in order to either increase the size of the phallus, to straight away go into gonadotropin. And from what I understood, is maybe HMG prior, HMG priming, and then go for HCG. And you can start that very early in life if the need arises. Now, this is a paradigm shift. What has been your phallic size improvement with this particular regimen? That's my question. And I have a second question. I'll come to that before this.
Sure.
After this.
So I think micropenis is something which is very disturbing for the family. I mean, the patients and the parents alike, they're very, very disturbed about it. And it's very heartening to see the response both for the micropenis and the testicular descent in these group of individuals. One of the things that we need to appreciate and respect is the fact that surgical management of testicular descent, because of the short spermatic cord, is quite difficult, and probably it endangers testicular damage as well in these group of individuals. So non-surgical management, which is over a defined period of time, is something which is very appealing for the parents as well, even if it is something which is definitely expensive. I mean, you can sort of tally the expenses of surgery versus expenses of medical management and so on. But both from the point of view of micropenis and the testicular descent, it's very rewarding. And I think the pictures were very, very representative of that.
So what would be the optimum age to try that?
So We have tried it as early, like right now in the department, there was one baby which presented at 2 months of age with multiple pituitary hormone deficiencies, and that baby is on gonadotropin-based regime for the management of micropenis and the testicular descent. So we've tried it as early as that to mimic the mini puberty. Even at 10 years, you're doing the same thing. You're mimicking the mini puberty, which is absent in that particular child. Even at 14 years, you're doing the same thing. You're mimicking the mini puberty. So it depends upon when the baby is going to come to you. So the earliest baby that I have in the department that we have looked after is 2 months of baby.
And was there success in the descent?
Oh, yes. Yes, they do very well. Yeah.
I think that's a very major take home. The
Yes,
other
please.
question I have is going back to those traditional days of what is it? Is it CDGP or is it HH? Wondering at 14 years of age, 15 years of age, 16 years of age, and then we used to give that, priming with testosterone, and then some would jumpstart and some wouldn't, and then with the passage of time, you would then conclude retrospectively this was HH, and then start a regimen with testosterone. What's your opinion on that?
Well, certainly, I think the time is going to be the major factor which will differentiate between the two most effectively. But as you will also relate to it, most of the parents feel extraordinarily anxious, even at about 14, and telling them to wait till 16 for us to generate that answer is very, very difficult for them to really work with. But the minute I have an older child, 15, 16, and if I have a child who's relatively not short, like Manjri's first patient, it was really challenging. 14 years, 7-month-old, not really on the shorter side. He was on a good centile. He was on a 50th centile curve, and we were worried whether he's really, kind of isolated hypogonadotropic hypogonadism that you're dealing with. But with that inhibin B, we said we'll wait it out and we'll figure out how he's progressing. And then every 4 months, 3 months, 6 months, there was a monitoring and a follow-up which was available. And the rise in the testicular volume was something which was heartening. You have to see the last follow was 16 years and 7 months, and the testicular volume was about 10 cc at that point in time. Now, 16 years and 10 cc still doesn't very tally that effectively. I would still continue my monitoring of that particular individual over a period of time, really, to see whether he arrests over there or he continues to march forward, really. Because many of these patients with partial hypogonadotropism, they'll stutter along the way and they'll stop somewhere along the way as well. So that's something that you need to watch out for. So your question, am I going to watch? Am I going to intervene? Am I going to interrupt with testosterone, letrozole? I think it will all depend upon your own strength of conviction, parental anxiety, and parental need of doing something, tweaking something. So that's where you stand.
Thank you. Well, the house is open, please.
Yeah, anyway, she gave an answer to the first question I had was, what is the earliest age we can start? So 2 months you have started the case.
Yes, please.
So that's good. So that means any patient who come even at 9 year, 10 year, the idea is to start mini puberty in them who are HH.
Yeah.
Now, what is the size of testes where we can tell that, okay, this patient will get spermatogenesis, is going to start?
That's a good question. So basically, this has been a major surprise and a major learning that I went through. I used to always say that before 8 to 10 ml, you hardly see any spermatogenesis. So we used to sort of take them to 8 ml and then only start looking at spermatogenesis, but not so really. We've seen even at 5 ml, at 4 ml. So as soon as patient can produce a sample for semen analysis, we have gone ahead and done the semen analysis, and we have seen sperm count being present in testes as small as 4 to 5 ml as well. So there is no fixed number that I can tell you about, that only at this number onwards you will see the spermatogenesis and not before that. There is no
so
such
one
thing.
more last thing. In hypogonadism, how long do we keep on giving this, your SCG and FSH? Once the testicular volume, because we have had patients who have started shrinking after that stopping of all this. The sperm count rose and suddenly the sperm count is down. So how long do we keep on doing this
And you take that
maneuver?
So in our patients, what we have done is as soon as the patient can produce semen, we have advised them to do the sperm banking. And once that is done, we decide to shift them to a testosterone-based regimen. Subsequently, when they want to go ahead and start a family, we put them back on the gonadotropins. That is what the protocol is at our department.
What is the regime of this gonadotropin? When they want to have a family, how do you give it?
We cannot hear you, sir.
You're not audible.
So what is the protocol regime when they want to have family? What do they do? How you give it? Keep on giving
So
them.
initially,
And how long?
so as long as fertility is achieved, we put them on that regimen. So once we have achieved the desired testicular volume, so initially if you have to induce puberty, it is HMG pre-treatment followed by HCG. Later on, we can, depending on the inhibin B levels, we decide either to put them on HCG alone or both combination of HMG as well as HCG.
My question is how long you will take to achieve sensitization of gonads with HCG or HMG if the child comes at 6 years of age?
So at 6 years of age, my only objective
Yes.
is to either correct micropenis, cryptorchidism, or prepare for puberty later on. I'm not going to induce puberty, nor anything else is a matter. I mean, none of the other social concerns exist at this point in time. So at this junction, like like these neonates we talked about, the infants that we talked about, we will use it only for a period of 3 to 5 months and not more than that. That's it.
One more question. Does achieving testicular descent by using HCG or HCG or HMG, does it exclude chances of neoplasm in undescended testes, up till undescended testes?
We don't know the answer to your question. So one of the questions that we always sort of want to work with, a cryptorchid testis has got a bigger risk of malignancy.
Yes.
What really needs to be related to fact is that it's generally a dysgenetic cryptorchid testes which has got a bigger risk of malignancy. Right? So hypogonadotropic hypogonadism with cryptorchidism, unless it has been long-standing cryptorchid testes with an increased risk of malignancy, by and large, when we talked about them or managed them in the newborn or infancy as a period, probably the risk of malignancy is not big, but there is no data, and we ourselves don't have that length of follow-up to give you the answer.
I would also like to add to that most of these patients with hypogonadotropic hypogonadism do not have intra-abdominal testes. They are in the inguinal canal. So that itself reduces the risk of malignancy in these patients.
Thank you.
We'll allow one last question.
Thank you, Manjari and Nalini ma'am. Always a pleasure to listen to you. My question is a bit basic. It's regarding HCG stimulation test and CDGP as well as HH. Both of these, primarily the testis per se is okay. So is the variable degree of HCG stimulation test result, is it because of FSH relative difference in FSH deficiency? Or why would some, like in Manjari's case, they passed the HCG stimulation test despite of having hypogonadotropic hypogonadism? So logically, because the testis is normal, I would expect that the testis would respond to some degree to HCG stimulation.
Absolutely.
So how is it helpful in
Absolutely. I mean, that's a basis of the whole questioning of this particular parameter, isn't it? That in hypogonadotropic hypogonadism, you're talking about the central governance, which is perhaps failing because of whatever be the reasons really associated with that. It's quite another matter that some of these genetic causes beyond central governance also have a testicular component of failure as well. But let's keep that aside as a part of the problem. The basic premises on which this HCG stimulation test works is primed versus unprimed testes. That's the basic fundamental reason under which it works. There is no other reason for it to work really, and that's why both are little children, 4-year and 3-year-old brothers, they both passed the test despite the fact that they had a severe degree of hypogonadism. They both came with micropenis, actually speaking, right? So they passed the test according to me, because this test by itself doesn't have that much of value addition as a differentiating factor between the two. But what Mehul Dattani's first picture and first paper tried to tell in 2009 was that you use them as a combination of 3 tests, not differentially all 3 tests together to give a diagnostic yield which is 100%.
Thank you.
Well, thank you, the speakers, for extremely vibrant session and the delegates for their participation. I think we'll close the session here and thank the organizers for creating this event.
Thank you for the wonderful session. And I would like to invite Dr. Subrata Day to felicitate Dr. Nalini ma'am and Dr. Manjri.
Okay,
Please.
thank you.